but we'd like to welcome everybody here this morning. And for those of you that are joining us for the first time, we're happy to have you here, and I hope that you will find this journal club engaging. Just a couple of quick housekeeping things. So we have, if you are signed up for CME, in order for us to verify that you are actually here, please go to the chat window and just type your name in there. Also, as far as discussion, if you have a question during the presentation, you can put it in the Q&A pod down at the bottom. And also, if you have any technical problems, like, you can't unmute yourself or something like that, which is what I was having, please put that in the chat. And for the CME, they want to make sure that we tell you that the panel who developed this program have no conflicts of interest to disclose. And so now that I've got that out of the way, I want to introduce to you our first discussant for this article today. This is Dr. Amy Dean. She is an OMM hospitalist in Mercy Health Muskegon in Michigan. And so I will turn the time over to her and bring up her slides.
Hey, thank you, Jane. Great, thank you. The intention that I set for this talk is to hear the author, Dr. Langevin's call to action regarding osteopathic research and to make us motivated as practice-based clinicians to participate in research, and also to hear her call to action to bridge and be more collaborative with other specialties that work in chronic pain and musculoskeletal areas and with those patients in a research field, but also from a practice perspective. So that's the intention I set for the talk. And next slide. And as Jane said, I have no conflicts of interest, and I'm also I'm honored to have this opportunity to speak about this paper. I think it's very relevant to what we're doing. Next slide. The article is entitled Reconnecting the Brain with the Rest of the Body in Musculoskeletal Pain Research. It's hot off the press. It was actually published this past January 2021 in the Journal of Pain, and it was written by Dr. Helene Langevin, who Dr. Alkes mentioned yesterday, and we'll be talking a little bit more about her background in a minute, because I believe it's very much tied in with what we do and to the calls to action that she makes in her paper. Okay, next slide. So there were a lot of things to read and digest in this paper. I think there are three main learning objectives, which actually tie in with the kind of main themes that she's presenting. The first is understanding that knowledge gaps exist regarding chronic musculoskeletal pain. And we'll be discussing a little bit more about that as we go along. The second learning objective or takeaway point is understanding what she calls that there are silos that exist within different fields of medicine that research and treat chronic musculoskeletal pain. And also that there needs to be bridging and cross-disciplinary research between these silos and sharing of knowledge and conducting research together for creating kind of a more inclusive and integrated research and practice community. And she divides those into 4 main categories, which are rheumatology, the neurosciences, orthopedics, and physical therapy physiatry. And we'll be talking a little bit more about those as well. And I want you to think about some questions as we go through this paper, because the way she wrote it is very osteopathic in nature. There are many points that either dovetail or are flat out osteopathic that she makes. So as we go through, I want you to think about, where do we fit in as a profession into these calls of action and to this integrative model that she's talking about? And also, do we have a responsibility with our knowledge and background to be less siloed ourselves and to be more collaborative with the other groups in this medical community? And if it does actually, in fact, help patient outcomes. Next slide, please. Okay, why did I choose this paper? There were several papers that I had looked at, and there actually was one paper that really piqued my interest that you all might be very interested in. It was a Lomana et al. Study on acute neck pain in patients that was manipulation, manual therapy of acute neck pain in females. And they were looking at neurotransmitter and cortisol levels pre and immediately post manipulation. That was more of a classic standard journal article and very interesting, something that you all might be interested in reading at some point. But I really thought that this paper that we're going to be discussing gets to the heart of osteopathy, the heart of osteopathic practice-based research, and has more for us to think about presently and going forward as well. I think it asks a lot of questions and gets us really thinking about where we're headed as a profession and as a research organization. So I think it's really important to consider those things. It was also written by Dr. Helene Langevin, and that, could you go to the next slide? I think I have her on the next slide there. Let's see, yeah. She has a very rich background in many different areas. Currently, she is the director of NIH's National Center for Complementary and Integrative Health. So she's leading a division of the NIH. She was, before that, the director of the Osher Center in Boston, which is an integrative medicine collaborative effort between Harvard and Brigham and Women's. She did her postdoc fellowship in neurochemistry at Oxford. She did her internal medicine residency and endocrinology fellowship at Johns Hopkins. And this next part I thought was most interesting because of her research interests, being the head of a division of NIH and having research interests that include the role of connective tissue in chronic musculoskeletal pain. And also research interests in the mechanisms of manual and movement-based therapies. And to have an NIH division director who is interested in the mechanisms of manual therapies, to me, is incredible. And I believe there are a lot of opportunities for us from her calls to action, and that she's actually open to our work, which I think is fantastic. Okay, if you could go to the previous slide. Another reason I chose this article was because it is open access and we can all read it at no cost. And it was recently published. So this is a recent call to action. This isn't old information. She's asking for these things this year. And I think that's very relevant to where we're headed, and both in research and practice. Last reason I chose this paper is because it's an area of personal interest. So at Mercy in Muskegon, I am the hospitalist for the OMM department there, and I depend on other practitioners and specialists consulting me in the hospital. So the hospital work is always very collaborative and kind of more of a close-knit group because it is what I depend on. And I do see the benefits of it. I see the benefits of working with the neurologists and the physiatrists and how that improves patient outcomes. And we learn from each other. And I think that is a really important thing going forward from a practice perspective, but also from an ACGME perspective, because they're calling for multidisciplinary interactions for our residents and fellows. So whether it's practice or training our future specialists or research, I think for many different areas, this paper is relevant to each and every one of us in what we do. Okay, next slide. Okay, next slide. Okay, why is this paper significant? Some of these things we've already touched on. It is a call to action to address knowledge gaps in chronic musculoskeletal pain research, which is very relevant to DOs. Chronic musculoskeletal pain is something that a lot of us deal with on a daily basis. And we have a lot of knowledge that the rest of the medical community dealing with this may or may not be aware of. And DOs can help fill this gap clinically and with research by being involved with a practice-based network such as DO-Touch.NET. And again, a question is, how can we support the medical community in being more aware of what we do? How can we fill in the gaps? Those are questions that I believe we need to be asking ourselves. Interestingly, she also calls for more research regarding fascia's role in chronic musculoskeletal pain. And just having attended virtually the British Fascia Symposium last year, my sense is that there's a lot of this going on overseas, and I think she's calling for more of it to be done here, which is important. And again, something that we work with every day, just from the beginning of our profession with Dr. Still, is fascia and its role in disease. I also chose this paper, again, because Langevin touches on things that are very osteopathic. She talks about the biopsychosocial piece. She talks about the neurologic piece and even the metabolic piece as an inflammation and rheumatologic expression of pain. And very much like our 5 models. And interestingly, she never mentions osteopathy in her paper, but she very much does touch on our principles and what we practice in our work. Next slide, please. Interesting, and we'll definitely be talking about this more, is she talks about silos that exist regarding the different fields, which I mentioned, the neurosciences, rheumatology, physiatry, physical therapy, and orthopedics. And that these silos of medical fields are doing their own research and talking among themselves, but they're not necessarily bridging to other fields. So it's kind of like the parable of the monks in India when they come across the elephant and they each put their hands on a different part of the elephant and they palpate the elephant, coming to different conclusions, but they never see the whole piece because they're siloed. Much like chronic musculoskeletal pain research in practice is each department or each field is siloed in their own area. And she calls for more collaborative research and more crosstalk between fields so that we can come to more complete conclusions looking at the whole patient and have better patient outcomes. And question to think about as we go through is, are we as a profession and as researchers siloed? Are we super siloed? She doesn't mention us in her paper. She mentions chiropractic. And is there a bridge that we need to build? And are there things that we need to overcome to reach out and let clinicians and researchers know that we exist? Something to think about, and hopefully a topic for discussion. Another reason this paper is significant, I thought this to me was just really got at the heart of our challenges for manual OMT research, is that Langevin discusses challenges of physical-based and manual therapy research with a call to action. So she recognizes that there are difficulties inherent in the research of proving efficacy of what we do. And it's not our fault that we don't always prove statistical significance, that there are inherent reasons that we can't always prove it. And it's not necessarily that our OMT doesn't work. It is actually that it is a very tough thing to research. And that was great to hear that a division chief of NIH recognizes that. The last reason I chose this paper for its significance is she made a very passing comment about using magnetic resonance elastography, which I had not heard about before, and did some reading about it. And I have a video to share later. It is super cool, I think. It is a way to correlate what we're feeling on a palpatory level. It actually is a way to measure tissue stiffness. So I'm excited to share that as well. Maybe some of you have heard about that and can comment on that for us. Next slide, please. Langevin breaks the paper down into 5 main points. She talks about pain in the brain. Second section is myofascial tissues, and that it is an important piece of the chronic pain puzzle. Third section is connecting the brain and body through motor behavior. And then mind and body approaches to chronic musculoskeletal pain. And her last section is bridging across silos. I thought she did a very nice job presenting questions for us to think about, and actually a lot of different research in the chronic pain area that kind of gets us thinking in different directions about potential research. I think she put a lot of ideas into this paper, and it's a lot of digesting to do, but well worth it. If you haven't read it, I definitely recommend that you might want to take a look. Next slide. Okay, so the first section, pain and the brain, she starts it right off and gets right into it. She talks about musculoskeletal pain model in the 20th century compared to where we are heading in the 21st century. So in the 20th century, she states that it's more of an orthopedic model. It's more biomechanical and fixing the broken part. So looking at discs and joints and kind of Newtonian type things. In the 21st century, we're moving toward a more neurologic and psychosocial model where we're actually looking at central sensitization, reduced descending inhibition, and functional and structural alterations that play a role in chronic musculoskeletal pain. She makes an interesting observation that the research pendulum is swinging from this biomechanical model to more of the psychological factors. And her concern that she states is that we're possibly neglecting some somatic components that exist, that it isn't necessarily all in the head, that there is some validity to the biomechanical model and other things that have yet to be researched. Next slide, please. So her question that she poses in this section is it the mind or is it the body that is involved with chronic musculoskeletal pain, or is it both? And if we swung so far with our pendulum, are we underemphasizing that there is tissue pathology that may be yet to be researched and studied? So her question is, when a patient experiences musculoskeletal pain for more than 3 months, is it all in the brain? Or do musculoskeletal tissue pathologies exist that contribute that we don't fully understand? And how do they interact, and how can we study that? And how can we prevent it? And I think it's important with her background as a neuroscientist and also her interest in musculoskeletal pain and manual therapy mechanisms of action that we ask these questions too. And many of us ask these questions in our practice probably on a daily basis, but perhaps we need to bring them to the research table and begin asking them in a larger context. Okay, next slide. She states that the role of myofascial tissues in chronic musculoskeletal pain is a substantial research gap area, and that soft tissue is becoming more and more recognized as an acute or as a prominent player in acute to chronic pain. She states that historically it was thought to be more brain and related to the nervous system, but there's new research coming out that shows that soft tissue actually plays a role in this acute to chronic transition. She talked about this interesting rat model where rats repeatedly pulled a lever for 3 to 6 weeks, and kind of like a repetitive use syndrome. And they were rewarded for this repetition. And when they looked at their tissue, their soft tissue, they saw chronic macrophage infiltration and fibrosis in tendons, muscles, and loose connective tissue. So her point is that there is pathology that's happening at the level of the tissue coming from the fascia. And it is not just the brain, it's everything. It's both. Next slide. Okay, this is where I thought it started to get interesting as well. She points out that for decades, we have talked about palpation and descriptions of tissue texture changes in the literature without objective evidence. Now she's talking about physiatry, and mainly Travell's trigger points is the tissue texture changes that she's talking about, that there are these palpatory findings that keep being reported on that there really is no objective evidence to support their existence. It's just based on practitioners, which is what we do too. We have tissue texture changes and that we find, and really no way to correlate these, although we keep trying to do reliability studies, things like that. There's been no technology to help us. So she states that there's been a rodent model that was developed for myofascial trigger points that has to do with soft tissue injury with repeated exercises, and it's similar to that study that she mentioned. So there is something that is a non-human model that can be studied. And then is when she mentioned the magnetic resonance elastography. And this is a way to quantify tissue texture changes, and it's just kind of coming onto the horizon. Next slide, please. So magnetic resonance elastography, maybe many of you have heard about this. I hadn't. And what it is it's magnetic resonance technology coupled with low frequency sound waves to evaluate stiffness of the tissue, which is tissue texture change. There was an article that was written, and this is open access as well. It was written by Maria Pan. It is a review of magnetic resonance elastography, and it talks about how this works and applications of it. So we know that palpation is used by clinicians to differentiate mechanical properties of normal and abnormal tissue. That's what's still always talked about, knowing normal from abnormal. So magnetic resonance elastography is an imaging-based counterpart to palpation that can quantify tissue stiffness. I thought that was incredible. So MRI, CT, and ultrasound are unable to depict mechanical properties of tissue detected on palpation, but MRE does. So it can actually pick up what we're feeling. And I want you to think about, is this something that we can use in practice-based research? And how could we collaborate with medical centers who have this technology to actually verify what we're finding? Next slide, please. This is a short video. It's about a 2-minute video. I just, for those of you who aren't familiar with this, as I was not familiar with this, just gives an introduction to elastography. This was put out by Mayo Clinic in Rochester. And just to give you an idea of what the technology is and get you thinking about how might it be used in osteopathic research and practice-based research. This is a video about looking at liver stiffness. They're using this more clinically in place of liver biopsy for cirrhosis and liver disease, but there are articles starting to come out that elastography is used in musculoskeletal research as well. Can we play that, Jane? Thanks.
Every day, doctors use ultrasound, CT scans, and MRIs to see inside the body without making an incision. Those tests are great at showing size and structure, but they don't show important physical properties such as tissue stiffness, which, for example, is a sign of fibrosis in the liver. But researchers at Mayo Clinic have developed technology that uses sound waves to see if a patient's liver is harder than it should be, if it's developing fibrosis. It's called magnetic resonance elastography, and it offers a non-invasive alternative to liver biopsy. Magnetic resonance elastography, or MRE. It combines MRI technology and low-frequency sound waves.
This is an MR image of the upper abdomen. And here, this very large organ in the upper abdomen is the liver. Now, looking at this liver with magnetic resonance imaging, regular magnetic resonance imaging, it's not possible to tell whether or not this patient has fibrosis in the liver.
But Mayo Clinic radiologist Dr. Richard M demonstrates that when used during an MRI, the new MRE technology shows, on a color scale, the stiffness of a liver. Here's how it works.
This drum generates waves in the abdomen.
The drum is placed on the patient's abdomen. The sound waves move through stiff tissue and supple tissue at different rates. A computer analyzes the differences and shows what's healthy soft tissue and what's not, like in this other patient.
This shows the sound waves moving through the tissues of the upper abdomen. This is the final product of this diagnostic procedure. It's called an elastogram.
And it shows if a patient has fibrosis and where it is in the liver. Many liver diseases, including autoimmune hepatitis, hepatitis C, and alcoholism, can lead to fibrosis. And if the condition is not successfully treated, the disease can progress to cirrhosis, for which the only treatment is liver transplantation. MRE is another tool in the fight against the progression of these diseases. Future uses of MRE may include imaging the breast, prostate, and other organs.
So hard to say. I'm not sure, but it seems like we've been waiting over 100 years to develop technology that catches up with Dr. Still was palpating and what we're palpating. And are we finally there? Do we finally have a tool that can confirm what we feel? And I wonder if there's some type of osteopathic research that could be done with this technology to verify what we're finding in a more objective manner, which is what research is always looking for, to confirm more objectively and validate findings. Okay, next slide.
Every day, doctors use ultrasound, CT scan.
Okay, next section is connecting brain and body through motor behavior. This is something that a lot of DOs work with on a daily basis. I know in our clinic, we definitely look at the role of motor behavior when we're looking at gait and seeing patients that we're treating for pain. Motor behavior plays a pivotal role in musculoskeletal pain is Dr. Langevin's point. And her point also is that body movements influence muscle growth and regeneration and connective tissue remodeling. And that reduced movement and inflammation can lead to adhesions between adjacent connective tissue layers. And these are things I think her point is that we need more research happening. And I know the fascia researchers are looking into this, and they're looking into motion of the thoracolumbar fascia and how reduced movement causes more nociceptors to form and things like this. And I think Langevin is right. If we can begin to bridge with these researchers and also to bring in the expertise that we have from a musculoskeletal and manual model, everybody benefits. Next slide, please. She states that knowledge, there's a knowledge gap that research needs to answer. So her question is, does the presence of fascial adhesions create abnormal load distribution through tissues that put vulnerable structures at risk, like joints and discs? Well, from all of the talk and research that's going on with tensegrity, I think there's a lot of possibility that it does. And we have this information. We talk about tensegrity and scars and how they change the fascia. And I think we have a lot to bring to this conversation and a lot of potential answers, or at least research that can lead to the answers through our practice-based research. She states there's more research needed on the cumulative effects of motor behavior in everyday activities on the structure and function of musculoskeletal tissues over a lifetime. And just a thought is how can we fill this gap in knowledge, since these are things that we work with often on a daily basis. Next slide, please. So mind and body approaches to chronic musculoskeletal pain. I think the main point that ties in with what we do is her comment of what we do. There's an overarching challenge of research related to physical-based therapies, including spine manipulation. And that has to do with the difficulty in standardizing across clinicians and their treatment styles. And interestingly, she doesn't see this as a burden or a negative. She actually states that it's a healthy challenge that can motivate better study design that will benefit research as a whole. And I feel like this is a wall that we keep running into, trying to prove efficacy. but she sees it as a healthy challenge. And she sees that researching manual therapies and their mechanisms is important. And I think if we can kind of see it through that lens as a healthy challenge, we can overcome a lot of the struggles that we've had in our work, knowing that it's inherent, that it is inherently difficult what we do and how to research it. Next slide, please. So she's calling for research design trials that are multimodal treatments delivered in a flexible package. So multiple treatments, and then comparing the effects of this package with standard of care. And I thought this was interesting because we spend a lot of time trying to prove the validity of what we do as a standalone treatment and compare it with sham or standard of care. And in the discussion, I'm just interested in what people's thoughts are on how does this work in osteopathic research, like clinical research. Are there pros and cons? Can we prove the efficacy of OMT if we're combined with multimodal treatments? Or are we too siloed, thinking that just treating with osteopathic manipulation is the answer? Do we need to realize that with chronic musculoskeletal pain, it is actually a network of treatments that results in best patient outcomes as opposed to one treatment? And she also mentions that research with individualized approaches that treat each patient as a unique individual may be the key to success. And that is exactly what we do with our osteopathic principles and OMT. And she's speaking osteopathically. And do we have a responsibility to educate her about our methods and research? Next slide, please. So that starts speaking to her last section, which is bridging across silos. So as I mentioned before, her point is that chronic musculoskeletal pain research is siloed between, next slide, please. Neuroscience, which deals with the neuroaffective pain processes, rheumatology, which deals with the inflammation and immune system, orthopedics, which has to do with the biomechanical piece, and physiatry, rehab, and physical therapy, which have to do with motor behavior. And what I think is interesting is osteopathy can sit at the hub of these four things. We deal with each of these things. And I know in Muskegon, in the Mercy OMM clinic, we're actually being integrated into the neurosciences department and have an opportunity to both inpatient and outpatient work closely with physiatry, with the neurosurgeons and the neurologists. And we're really at the hub of this diagram. And are we missing from this diagram? Do we need to do more to bridge and collaborate? Next slide. So Langevin calls for cross-disciplinary research to be integrated across these four fields that are siloed. And that, interestingly, she dives a little bit, very briefly, into the visceral connections of chronic pain. She starts talking about interstitial cystitis and irritable bowel disease syndrome, and the fact that musculoskeletal pain has a bigger network than just musculoskeletal pain. That what are the connections to the viscera, and does osteopathic have a role to play here as well? Because we already know about viscerosomatic reflexes and how they integrate into our work. And what is our role here research-wise? Next slide, please. She does make a point that identifying knowledge gaps is an important point to understanding the whole body and results in better understanding of the body as a whole from a pain perspective. She talks about collaborative research between silos, such as brain and behavior and tissue structure, the musculoskeletal system and immune system, and the musculoskeletal and nervous system. And of course, there's a lot of research going on now as well about psychoneuroimmunology. So it's already in the literature. These aren't new ideas. This is just breaking down barriers between the fields to begin sharing and collaborating. And I think the question is, what does this look like from an osteopathic research perspective? How can we participate in this, both for the longevity of what we do, and also just to share and have best patient outcomes. Okay, next slide. she makes the point that tissues and structures are often studied in isolation from the surrounding anatomically connected tissue. So she makes the point that fascia is often left out, aponeuroses are often left out, even though they're integral to the functioning of a joint. And my impression was also with the fascia researchers such as Guillaume Barteau and people looking at fascia in the overseas research community are starting to try to put these pieces together and answer these questions. And I think it was mentioned yesterday, the benefits of being part of the fascia community. I think it's so integral to what we do. It only benefits us and the larger research community as a whole. Next slide. Langevin is calling for musculoskeletal pain research to be fully integrated across multiple disciplines. This is kind of a summary of her thoughts. And heading into the discussion, I just would like to hear, obviously, from Dr. Degenhardt, Jane, and those listening, how do we do that? And what are the benefits and risks of doing that? And to do this, she's stating we need to bridge across tissues, anatomical areas, and body systems, that we have to stop compartmentalizing and look at things in a whole person approach, which is exactly what we do. And again, very osteopathic in her thinking. So I think the big question is where do we go from here? Next slide. When we get to the discussion section after Dr. Degenhardt, I think some questions are, do her questions or calls to action apply to our profession? And do they also apply to our residency and our fellowship training programs? As I mentioned in the beginning, ACGME is calling for multidisciplinary work for our residents to be involved in on a clinical level. This can apply to a research level as well. I believe it would only increase our credibility to be working and doing research with rheumatology, neurosciences, and ortho. And then what actions can we take as a profession, both clinically and research, to answer the calls that she's made? Thank you. Oh, last slide is evidence-based references for those who are interested.
So thank you all. Thank you, Amy, for that. Perhaps before Dr. Brian Degenhardt speaks, we have one comment or question from Greg Heller. He says, I believe MRE is not the only way to measure tissue elastography. FibroScan, I believe, is ultrasound alone without the MRI component. I've seen hepatologists using FibroScan with my patients over the past 1 to 2 years. So, and he provides a link that's in the Q&A. So
I think that's actually a cheaper method too, so, and more readily available. So I would be interested in hearing people's thoughts on that too for researching our findings.
excellent.
Yeah, thank you for sharing that.
All right. So it will turn some time over to Dr. Degenhardt.
Thank you, Jane. Thank you, Amy. What an amazing presentation. You did an awesome job.
Thank you.
And I'm hoping that everybody understands how personal we should be taking her message. Because in the past, we've often hidden from our responsibilities as people that have the most global understanding about health and pathologies, to say, well, everybody else is keeping us from being able to, disseminate this work and to advance this work. Well, that just doesn't exist anymore. I mean, now the leader of NIH is clearly in all ways speaking osteopathically, and we can complain that they're not using our term, but the reality is Dr. Still, that didn't matter to him. He wanted to change the process of medicine. He didn't by himself want to create a separate profession, a separate ideology. And so it's there. The time is now finally here. And so we need to take advantage of that. And so I have no direct financial relationships to what I'm going to be presenting. And I would say really all I'm going to be doing is hopefully facilitating some discussion, because I'm going to make sure that what Dr. Langevin has stated is something that we take into our practice every day. And because her questions are relevant to what we do and how we think. Part of the issue of when we're looking at tissue texture characteristics is when we know that there's a lot of diversity in what our instruments define. And so the question is, how are we defining it within our own hands? How are we defining it from one individual to another individual, particularly when we're looking at ways of collecting information throughout a practice-based research network where we have over 700 members, which means we have over 700 separate instruments that are processing information, and we're collecting that information to have meaningful, data for the research that we're doing. And then if we're going to bridge silos to be able to communicate that in such a way that it's going to influence these other groups in how they do research. And so with that, if we can go to the next slide. So the questions that I just want to offer is, first of all, how do you clinically think when you are dealing with a chronic musculoskeletal pain patient? So you can think about the low back pain patient. That's a very easy individual and complicated individual to deal with. So Dr. Langevin talked about these different underlying mechanisms or factors that we might be thinking about. Which one do you which of these lenses do you use when you're working with your patient clinically? Because and then what is the current evidence that you are aware of that kind of supports that framework of your practice? If we're not up to date on our understandings, then our influence in the work that we do with our patients within the global medical community is going to be limited. And as Amy said, and as we all know, that osteopathic model has always been conceptually in the forefront. Right now, Dr. Langevin and the NIH and researchers in general are seeing finally what the osteopathic model has been saying for over a century. Are we going to still be in the forefront of engaging them in the data we collect clinically that's going to help to mold and shape the research agenda that's occurring in basic science labs, but also kind of help to bridge a whole new model of research that includes clinicians and basic scientists working together? Go to the next slide. So the knowledge gaps, are we beyond fixing the broken part? And how often do I hear when I have residents report to me, well, there was they had somatic dysfunction at T4, it was rotating side bent to left, and they did their technique and that was it. The world was good. Well, that's still that idea of just fixing the broken part. They didn't think any more deeply about, the central nervous system factors, the sensitization issues, circulatory issues, the inflammation and biomarker related issues. So we really got to get a handle on the processes of how we're thinking when we're with our patients. What model are we working from? What models are we not thinking about that we should be thinking about to advance the care that we're giving them? Having worked with the International Association for the Study of Pain since the mid-90s, it was very clear in dealing with pain that because MRIs, X-rays were not showing a structural reason for the pain that people were complaining about, that drove the research area into the central nervous system to say it is due to central sensitization. These are neurologic pathways, that this is no longer a real physical issue. It is a software issue. And I never felt good about that, because you could feel. And the patient would say, when you touch this area, this is painful. It's not just coming from the brain. And it was amazing to see that Dr. Langevin was finally re-acknowledging that we got to reconnect these things. And I think as clinicians, this is something that we just, have been recognizing as osteopathic clinicians. So what is it that we think we're doing when we're differentiating between normal and dysfunctional tissues? Do we have confidence that if we're standing in the same room and evaluating the same patient, that we're going to find fibrotic changes in that erector spinae in a similar fashion? Are our instruments as calibrated as they need to be? We got to be always challenging ourselves to increase our manual skills, to be honing into into reliable, objective findings regarding the human structure. And then how do we report what we're feeling? We can say from the research that we have done, Jane can speak to this, and when we look at the reliability of our physical examinations, it's not as good as we should. And so constantly, we're very good in these conferences to jump in and learn about, a new technique, and this is what I do. But do we ever spend any time in saying, this is what the tissues feel like? And what are the words that we're using to describe that? So that when we use one set of words within my clinic, that means something to, another clinician, and that we can compile that information. Next slide. Okay, so I think pretty much these are things that Amy had just really spoken very clearly about. So I'd just like to see if we can open up a little bit discussion before I will need about 5 minutes. So let's take 5 minutes, just open up some time for dialogue, and then I will give us a vision of the future.
So if you would like to make a comment live, please feel free to raise your hand. We'll start with a comment here from Kate Warden. Just says, how did she get this so osteopathic without acknowledgement of osteopathy?
Well, I can say that Dr. Kendi Hensel sits on her board, and so she has osteopathic representation. But I can say just within A.T. Still University, where we have multiple, health science programs, and they, when you are coming from an outside model, the term osteopathic is not the term people gravitate towards. It's our term. It'll always be our language. And if we're going to wait for everybody else to accept that using osteopathy or osteopathic philosophy, it's just not going to happen, because it's not descriptive. It's like using a person's name to describe a technique. We are moving beyond that as a society. And as long as the osteopathic philosophy thrives, to me, that's what Dr. Still wanted in the first place. So, we don't want to get into that issue. Well, that's osteopathy and they're not giving us credit. Well, let's give them credit. One, they came to it from whatever route they did. And the reality is that is the right approach. We want to support that in every way we can. And whatever terminology we have, they'll end up recognizing it when it's appropriate.
I think that's a really interesting point. Treating patients in the hospital, they don't know what osteopathic medicine is. And sometimes I think it's a barrier to treating them. But when I describe what it is, they're very much on board and they do want to be treated, you know, and I think sometimes we get caught in the label or the term and people just get confused maybe, you know, even though we're all on the same page ultimately.
Yeah, there are many issues that we can discuss on this level, and unfortunately, we can't go to the golden bee in order to do that, but maybe at another one.
Yeah.
All right, so Jed Downs has his hand up. So you'll have to unmute yourself.
Yeah, there's just, okay, I am unmuted, I believe.
Yes,
Am I?
yes.
Yeah, I was thinking that, you know, I hadn't heard of MRE either, but I was thinking that, you know, just working with scar tissue is probably the low-hanging fruit as far as approaching it. If we know that we have painful scars and we could establish a baseline of what non-painful scars look like, what a painful scar looks like before treatment, and what a painful scar looks like after treatment, and whether or not there's been any impact as a result of the intervention on that painful scar. That seems to be a low-hanging fruit to be able to show the efficacy of manual therapies on that scar. That's it.
That's great. I like the thought process.
Very good. So next we have a hand up from Kevin Pineda.
Yeah, can you hear me?
Yes, yes.
Hi, my name is Kevin Pineda. I'm a PGY2. I'm in Custer PM&R up in New Jersey. So I'm a physiatrist that's really interested in trying to bridge the gap between osteopathy and PM&R. I think one of the pet peeves I really have when I look at PM&R research is that when they talk about different modalities, they talk about manual therapy, but they talk about it in the context of like chiropractor massage, but they never really talk about like a little bit of like OMT. I've always wondered, why don't we, if physiatry and OMT makes so much sense, why is there such a big gap in trying to include us of conversations with, especially with research? Definitely would love to be involved in like the multidisciplinary approach. I can talk about a little bit of my clinical approach when I looked at certain patients. So one of the rotations we do in pediatrics is children's special hospital inpatient. There's a chronic pain program where a pediatric patient spends about a month multidisciplinary with psychologists, occupational therapists, physical therapists, physiatrists. And specifically, one of the patients we see is amplified musculoskeletal pain syndrome. And I actually find this syndrome kind of fascinating because I see it as an autonomic dysfunction rather than a pure musculoskeletal, pure central nervous system type of problem. So a lot of what I try to do is when I look at a patient such as her is, because she has pain all over, it's like, where do I start? So I kind of go back to what Dr. Fulford or what Dr. Still says, is basically looking at the breath, looking at the diaphragm, and kind of going from there, because there's a lot of talk of how a lot of the fascia originates from the diaphragm. So I definitely I feel like I definitely take more of an autonomic approach of calming down the sympathetics, helping the parasympathetics, and then from there going to like the most pain sensitive areas. And I feel that for the patients I treated where they have like whole body pain syndromes, like even talking like fibromyalgia, for example, I feel like I had good results with that. In terms of trying to quantify, try to have objective evidence is really tough to say. I've been thinking about how to approach that, especially for like COVID patients, for example. In the rehab hospital, I treated a patient who, you know, I guess we can call like long hauler syndrome for COVID. And this patient, he already has a debility in terms of lung function. And when he had COVID, he started to have difficulty breathing, even though he didn't need the vent anymore. So for him, I worked on his lungs. I worked on the autonomic type of approach. He ended up being able to, quote, breathe a lot better, and he was able to do physical activity, physical therapy, occupational therapy much better. but I didn't really have any objective evidence. And one of the ideas I was brainstorming is vital capacity something that we could measure that would be objective evidence to show that using OMT for COVID lungs or COVID long haulers would improve.
Kevin.
Just some ideas out there.
Yeah, thank you for those comments, Kevin. And I certainly would like to talk to you more about that. Just to let you know, that initiative coming up in DO-Touch.NET is a study to look at people with post-COVID syndrome. We had a presentation yesterday evening within the Academy on that. And so that's coming. It was brought up by membership in January as an area of priority for us to consider. We have put together a methodology for that, and we're hopefully going to be able to reach out to membership to see those who are able to help participate in answering exactly the questions that you're raising. So just because of time, I need to quickly wrap up, and I really appreciate everybody's participation, and we'd love to continue with the discussion. We have times during the breakout session that we meet, so come back to our booth, so to speak, and we'll keep carrying on the conversation. If we can just pull up the slides real quick, Jane, for my final few. So the issue that Dr. Langevin talked about was the issue of silos. And so within the AT Still Research Institute, if we can go ahead and move to, we have recognized this issue now for several years. I've been working with Francesco Ceratelli. Some of you may recognize the name. He's an Italian osteopath and a neuroscientist who has done a lot of osteopathic work, and Paul Standley from the University of Arizona, who we all know, in the establishment of the International Consortium on Manual Therapies. And this organization is a platform to bring together the various silos, not just within manual therapies, but also anyone that has a direct association with structure function relationships. And so our vision is that we're going to help shape and advance healthcare through improving our communication and our collaboration, both clinically and in the research area. So if we move on to the next slide. We're going to move through these pretty quickly. So we are offering our initial conference is going to be May 6th, 7th, and 8th in 2022. It was scheduled for this May, but just like everything else with COVID, that has now been delayed. We have working groups already established that are working in 3 different topic areas. One that's looking at just the nomenclature. How can we begin to communicate better? So looking at the procedures that we are using and looking at how those are similar across professions so that we can actually communicate with each other. We have another group looking at physiologic theories. What is our understanding, our beliefs about what we're doing, and seeing how we are similar or different in regards to that. And the third topic area is looking at the current evidence in approaches for manual therapies. And then we're going to take that evidence and look at our theories and bring them together to help to clarify what is evidence-based now, what is not known, what is clearly evidence refuted, and we need to move beyond it, and help to lay out future agendas for research in this area. And we have 3 other conferences already in development for this consortium. So I think you can see there at the bottom, icmtconference.org. You can get more information about that conference. Just for the next slide, Dr. Langevin is one of our keynote speakers. Go ahead and flip through that. You all have gotten a good information about her. And then also Dr. Lars Graven Nielsen. He is an amazing international researcher. He's an MD, PhD, who does a lot of research on the musculoskeletal system and pain. He was the president of the International Association of the Study of Pain. And so he's going to be helping representing kind of the basic science and the bridging that is already going on between the clinicians and the basic science world to help us understand how to further develop along this line. So I'm really interested in reaching out to anybody who's wanting to get involved in this level of work. The A.T. Still Research Institute is funding and leading this initiative. So come to the booth again and we'll talk more so I can give you more information. So thank you so much. Thank you for attending. Thank you, Amy, for a wonderful presentation. We look forward to getting back together with you throughout the conference.
Great. Thanks so much.
And I will just also promote that we will be sending out the recording of this, and we will be it'll be posted in our discussion forum on the DO-Touch.NET website, accessible by DO-Touch.NET members. And so we hope that the discussion will continue there as well. Thank you all for coming, and have a good rest of your day.
Thank you. You too.
Thanks.